Good afternoon, everyone. It's always a pleasure to have outside speakers for medical grand rounds, and we can learn from their expertise and their experience. But it's even more pleasurable when one of those outside experts is one of our own former trainees, and that's true of our speaker today, Steve Hodak. Steve is a true Hoya, or at least let's say 80% Hoya, not undergraduate. But he went to medical school at Georgetown. He did his residency here at Georgetown Hospital, including being one of our chiefs from 2002 to 2003. And then we were fortunate enough, although Ken Berman and I always debate that term fortunate, but we were fortunate enough to have Steve join our joint endocrinology fellow training program between Georgetown and Washington Hospital Center, where he excelled as one of our fellows. After that, he was recruited to the University of Pittsburgh, where he was an associate professor of medicine and the clinical director of the endocrinology program, and really expanded the program, the clinical program, to a degree that most of us were envious of in terms of how large and good that program became. In 2014, he again relocated, this time to New York City, to NYU Langone, where he is a professor of medicine at NYU still. He was the chief of endocrinology at Tisch Hospital and the assistant director of endocrinology for the whole program up until early this year, when he relocated to Maryland, at least for the time being. So Steve is a real expert, an acknowledged expert in the approach to diagnosis of thyroid nodules, an extremely common problem in endocrinology, but also I would say in all of medicine. He's got 37 peer-reviewed publications, 9 chapters, and has given talks around the world on the best practice for diagnosing thyroid nodules, and that basically means differentiating thyroid cancer from benign nodules. But also, as you'll see today in his talk, he is very adept at adapting new technologies to both the diagnosis and treatment of thyroid nodules, and that's what we're going to hear about today. So Steve, it's a pleasure to welcome you back, even though you're like, I don't know, 2 miles away. But virtually you're here at Georgetown, and we're happy to have you here.
Thank you very much for the introduction. I just want to point out that I have no relevant disclosures. Sadly, at this point, I have no financial disclosures, and it would be nice if it were otherwise, but that's the situation right now. I wish I was the one who had originally created this slide, but I shamelessly stole it from Susan Mandel because I think it is so telling. This is a headline from the New England Journal from 1964, and it's entitled "The Nodular Thyroid Gland in Cancer." And one of the sentences that I selected was how to select that patient with a nodular thyroid gland in whom there is the greatest likelihood of finding a cancer is still the subject of considerable disagreement. We've made a lot of progress to try to untangle that conundrum. And I'll talk to you about some of the important discoveries and the key technologies for the evaluation of thyroid nodules in cancer. Namely, those are neck ultrasonography, thyroid cytology. I'll spend quite a bit of time talking about an important topic, molecular genetics and molecular diagnostic testing. And then at the end of the talk, I'd like to introduce one new therapy for thyroid nodules called radiofrequency ablation, which I think is very interesting and offers a non-surgical approach to management of nodular thyroid disease. So arguably, we've come a very long way from these very crude two-dimensional A-mode ultrasound images that were created in the late 1960s when ultrasound was first starting to play a role in evaluating thyroid nodules. And you can see pictures of what a normal thyroid gland looks like in panel A on the left, with multiple spikes and some areas of attenuation, a thyroid cyst in panel B, which is primarily areas of attenuation, and then perhaps not surprisingly, a mixed solid cystic nodule, which has some spikes and some areas of attenuation. And this, I think, was more of a curiosity than it was really helpful, but thyroid ultrasound has dramatically evolved, and we're now able to create incredibly detailed and very informative pictures that not only tell us how things look, but allow us to create rubrics for risk stratifying nodules based on appearance. And here I'm showing you 3 nodules, a cystic nodule, a mixed solid cystic nodule, and a solid nodule. And the idea is that as nodules become more solid, the possibility of them becoming malignant increases, though there are many features that are more significantly associated with malignant nodules, which I'm showing in the panel below, where you have heterogeneous nodules that have a poorly defined vascular halo around the circumference of the nodule, markedly hypoechoic nodules or anechoic nodules. And then this nodule that's in the bottom right corner that is an ultrasonographic papillary cancer until proven otherwise. It's anechoic. It has multiple internal echo reflectors that are microcalcifications. It has a very irregular spiculated infiltrative margin. And though it may be a little bit covered up with the words, it looks like it's actually breaching the anterior thyroid capsule. So ultrasonography is a very important way for us to understand thyroid nodules. We can also predict benignity, and I was interested to learn that this study, which I had heard about many years ago, actually came from NYU, where I now have my academic appointment. The most important observation in this study is the observation of what's now commonly referred to as the spongiform nodule. Spongiform nodules look exactly the way they sound. If you can imagine looking at a sponge, there are multiple small cystic spaces distributed throughout the parenchyma of the nodule, and these nodules are universally benign. Colloid nodules in the next panel with these echo reflectors with this characteristic comet tailing or ring down artifact are also benign. Then they have these kind of crazy nodules that they gave these names to, like the giraffe and the white knight. These are all hallmarks of benign nodules, and in this study, which was retrospective, they noted that if they had applied these criteria for selecting these nodules prospectively at the time the study was done, they would have eliminated the need to do fine needle aspiration in about 60% of the nodules that they studied. So they're very common as well. And the point is, we're very good at understanding what benign looks like and also what malignant looks like with ultrasonography. Organizations have tried to push the envelope on the use of diagnostic ultrasonography for risk stratifying nodules. Here's the rubric from the American Thyroid Association. This is an interesting whole nodule pattern-based approach where nodules are depicted with pictures. And the idea is that you're supposed to look at your nodule and figure out which of these nodules in the rubric your nodule looks most like. And you're able to risk stratify. So if you have a purely cystic nodule down here on the bottom, the likelihood of cancer is extremely low, probably less than 1%. And there's no indication for fine needle aspiration. If you look at the nodules in the top row, these have the features of overt malignancy where the risk of cancer is very high, FNA is clearly indicated, and then there are several shades of gray in the middle. The American College of Radiology has a different system, and I'll stop for a minute to observe that the American Thyroid Association has an image-based rubric, and the rubric from the ACR, which is a bunch of radiologists that look at pictures all day, is actually descriptive, so somewhat ironic, but this is the approach that they take, where they look at features like composition, echogenicity, shape, margin, and whether or not echogenic foci are present. A score is created, points are awarded based on the presence or absence of these features, and the cumulative Tyrad score, thyroid imaging reporting and data system score, then informs the recommendation about whether FNA or observation is most appropriate. So the real question is how well do they work? And I'm not sure what system you're using at Georgetown. We're using the Tyrad system at NYU. I think on paper, it looks like a great system. In actual fact, I think it's okay, not great. This is a very nice paper that just came out a few months ago that looks at accuracy for correctly scoring nodules in a large patient series from a single institution. And you can see the AUC in this receiver operator curve is about 0.68 for Tyrads and ATA both, meaning that there's moderately good agreement, meaning that the accuracy is pretty good, not fantastic, but certainly not poor. I think the real falling down point for all of these systems is the inter-rater agreement. So I call it chocolate. Do you think it's chocolate, or do you think it's vanilla, or do you think it's not even ice cream? And that's really the downfall. There's too much disagreement still in these systematized approaches to evaluating thyroid nodules. And the inter-rater agreement of 0.4 is really pretty fair to lousy, as a matter of fact. So I think we need alternate strategies for evaluating nodules, and it may be that artificial intelligence is the way that we'll work this out. This is another recent study, and there are many others like this. This one happens to look at convolutional neural network analysis. They developed their network using a 482 nodule training set and then 103 nodule validation set. And what they're effectively doing here is they're taking their image of their nodule and they're automating or using AI to mechanize the application of what appears to be sort of like the ATA criteria. Which of these reference nodules does the nodule under investigation most look like? Doing this in this reasonably sized study returned a pretty decent negative predictive value of 93%. So 93% likelihood that if the test says the nodule is not high risk, it isn't. And a positive predictive value of about 65 or 66%. The negative call rate is about 57%, meaning that about 57% of nodules that are investigated receive a diagnosis that obviates, eliminates the need for FNA. So I think this ultimately will be progress, and it's sadly, I think we're facing that we have to take the human element out of the equation in order to do this sort of analysis correctly. So where are we with ultrasound? It is enormously helpful in the evaluation of thyroid nodules and structural thyroid disease. I would not want to practice thyroidology without having access to a neck ultrasound. It remains the absolutely best method for imaging structural disease in the thyroid and the anterior neck in the regional lymph nodes. I think it's fair to say we do not yet have a highly reproducible systematized approach to ultrasound evaluation. And as I often tell people, just because you have a wrench, it doesn't mean you're a good mechanic. You can have all of the flight plans and all of the tools you need. It doesn't mean you're going to get the airplane off the ground. Both the ATA and Tyrad systems look great on paper, but I think implementation and consistency remain a challenge. And I would be interested at some point in learning what system you're using at Georgetown and how it's working out for you there. One of the other pillars in evaluating thyroid nodules is thyroid cytology. How do the aspirate smears look under the microscope? So this is a mock representation of what an FNA looks like. Most of you probably know this is an ambulatory outpatient procedure. You can tell that this is a mock-up because this person who's holding the ultrasound probe is not wearing the glove, and there's no needle on the end of the syringe. But that makes my assistant, Lori, very happy. She was kind enough to pose for us. So this is what an ultrasound looks like. If you look at it ultrasonographically, landmarks here, you can see the trachea, the carotid artery, jugular vein, the strap muscles are up here. Here's a thyroid nodule, and you can see the needle very nicely being placed inside the thyroid nodule to obtain the aspirate, which we then look at under the microscope. This is an old paper, but it's a very good one. It's from Hossein Garib at the Mayo Clinic. It's from 1993, and what the paper is showing is the decade or so around the time that fine needle aspiration and cytology was introduced at the Mayo Clinic for selecting patients for thyroid surgery. And while the number of cancers that were identified at surgery over this decade did not change, the number of surgeries that were required to find those cancers dramatically decreased as nodules could be better selected by cytology, meaning that when we eliminated the low-risk cytologic nodules from consideration, the higher risk nodules that went to surgery were more likely to yield a positive cancer diagnosis. About 70% of thyroid cytology is benign, meaning that the pathologist will look at it and say, this is not cancer, this is a benign nodule. And in those cases, the management is pretty clear. This is a very low risk situation where observation, possibly a repeat FNA and additional imaging is the usual course of business. In the 5 or 10% of cases that are malignant, management is also, I think, fairly clear because the risk of cancer is high, though it's very current now to offer observation to appropriately selected small intrathyroidal cancers. Most thyroid cancers result in some form of surgical management, whether it's lobectomy or total thyroidectomy. The problem really is the 20 or 30% of cases that are indeterminate, where the pathologist cannot tell us whether the nodule is benign or malignant. And when you consider that there are probably something on the order of 600,000 FNAs done annually, 20 to 30% is something like 120,000 to 180 cases that wind up being indeterminate in this gray zone where we can't reconcile them just based on cytology. In the old days, we used to take all of those patients to surgery, all of those indeterminate cases to surgery, and we would do a diagnostic lobectomy in most cases. And these are the results from a large series of cytologically indeterminate nodules. And you can see nearly 90% of the nodules that are managed surgically are benign. And we would pat ourselves on the back and congratulate ourselves and tell the patient who just went through general anesthesia and intubation and the possible risks of bleeding and infection and now has a permanent scar, missing half the thyroid and may wind up on thyroid medication. Good news, you don't have cancer. And in about 20% or 10% of cases, we had to tell the patient they did have cancer and then they might need surgery. And this was a very expensive way of finding cancers because lobectomies cost money, thyroidectomies cost money, completion thyroidectomies cost money. But until very recently, that was the best way that we could offer treatment to these patients. A big step forward in 2008 was the adoption of the Bethesda Criteria after an NIH-sponsored consensus conference. And I think that is probably what you're using at Georgetown, and it's being used throughout most of the country and around the world for that matter. And the Bethesda Criteria basically breaks down cytology results into one of 6 categories, ranging from non-diagnostic to malignant. And the original intention was for these categories to have an escalating or de-escalating, depending on which way you're looking at it, level of risk. In the center, the purple bars, Bethesda 3, 4, and 5, are the cytologically indeterminate nodules with an increasing level of risk, as you see all the way on the right. The idea of this rubric was that it was supposed to, again, systematize the way we approach thyroid cytology evaluation and create more uniformity and standardization. So how has that worked? This is a very important paper from 2013 from Ed Sebas from Massachusetts. He was one of the authors of the Bethesda Criteria, and this is sort of the proof is in the pudding paper. This is 336 nodules that came from a variety of academic and community practice sites. The submitting diagnosis from the submitting pathologist is here on the the left side on the y-axis. And then the central cytopathology overread by the expert, internationally recognized expert panel of cytopathologists is along the top. And the question the paper is trying to answer is, how often does the expert panel agree with the submitting diagnosis? And I've bolded that for you, and you can see, especially for these indeterminate cases, agreement is actually kind of lousy. About 2/3 of the time, the experts agreed with the submitting diagnosis for this category, FN, SFN, follicular neoplasm, but about 1 in 3 times did they agree for these other 2 categories of indeterminate. And if you look, you can appreciate that in any of these categories, the discrepancy between how these experts classified these nodules compared to the submitting diagnosis is really sort of all over the place. The most important observation, I think, from this study was that when these experts went back and read their own cases 30 days later, they disagreed with their own diagnosis 25% of the time. So this led Ed Sebas to say substantial inter and intra-observer variability exists in the cytopathologic evaluation of thyroid nodules. confirming an inherent limitation of visual microscopic diagnosis. Basically meaning we've sort of pushed microscopic diagnosis as far as we can push it, and it's not going to get to the truth in all cases. The good news is that in the early part of the 2000s, a clinical innovation was happening, and that was the clinical innovation of molecular genetics. And I think that's really changed the way that we've evaluated thyroid nodules and thyroid cancer, and that's the next topic I'd like to talk about. When I got first involved in molecular diagnosis of thyroid nodules, what we knew was that for the most common thyroid nodules, papillary cancer and follicular cancer, which are most prevalent, comprising about 95% of all thyroid nodules, a relatively small number of genes were present in a very large set of these nodules. And in fact, those same genes were highly present in other types of cancer that were far less prevalent, like poorly differentiated cancer, anaplastic cancer, and medullary thyroid cancer. So the question became, can we use these genes in a way to start figuring out what's going on with these cytologically indeterminate nodules? The next concept that's important for understanding molecular diagnosis is the idea of neoplasia versus hyperplasia. So what is neoplasia? Neoplasia is a tumor that starts as a single progenitor cell that divides and then redivides, and those daughter cells divide, and that tumor clonally expands to form a lump where all of the cells in that tumor have genetic homogeneity. They all derive from a single progenitor cell. And that is a clonal neoplasm. When those clonal neoplasms carry mutations, the tumor will express that mutation diffusely throughout the cells in the tumor. When you have something like a BRAF V600E mutation, which many of you know about, common in colon cancer, melanoma, thyroid cancer, a number of other cancers, you wind up with classic appearing papillary thyroid cancer. If you have a mutation that's more like a RAS mutation, one of the most common mutations known in human tumors, if the tumor is not invasive, we would call that benign follicular adenoma. If the tumor starts to develop abnormal cellular appearance, we'd call that an atypical follicular adenoma. And then those tumors can go on and progress to ultimately become invasive and a follicular thyroid cancer, or a nodule that we now acknowledge as an intermediate transitional nodule, NIFT-P, a non-invasive follicular thyroid neoplasm with papillary-like nuclear features. But the take home is that all of the cells in the tumor should express this same clonally expanded mutation that we can then test for with these various methods. Contrast that with a hyperplastic nodule. So a hyperplastic nodule is different. It's a bunch of genetically distinct cells that just sort of organize themselves into a lump in the thyroid. And these cells can never become cancer because they are not clonal. This is not a neoplasm, and it cannot become invasive. Why is that important? So this is one of my papers from a number of years ago. This is a papillary thyroid cancer in the center, and you can see that there are several areas marked A, B, and C. What we often teach the students is that these areas look very different. Area A looks very blue, area C looks very pink, and area B looks something in between. And that's because these areas have different histologic features. Area A has the well-developed features of papillary thyroid cancer with the typical abnormal nuclei, very densely packed, not a lot of stroma, not a lot of cytoplasm, and typical features of papillary cancer. Whereas area C actually looks normal. It has big lakes of colloid with palisading epithelial cells. There's nothing really abnormal about these cells, and area B looks somewhere in between. Now you can imagine that if we were doing a fine needle aspiration in this nodule and we put a needle into area C, the cytology would probably look benign. If we were lucky enough to stick the needle in area A, the cytology would look malignant. And if we stuck it in area B, it would look somewhere in between, and we'd be very confused. But the important point of clonality is that because this is a tumor, it's a neoplasm that's been clonally expanded. If we look at all three of these areas in terms of molecular diagnosis, They all three have the same genetic endowment, in this case, a RAS mutation. And what's different is that the histology in the tumor may be heterogeneous, but its genetic heritage and the genetic driver mutations are uniformly present throughout the tumor. So those are the important concepts for understanding how molecular diagnostics work. So in 2007, we had something that we called the 7-gene panel in Pittsburgh. It was 7 isoforms of these genes, BRAF, RAS, RET-PTC, which is a gene fusion, and PAX8P PARGamma, another gene fusion. And primarily because BRAF mutations are so highly prevalent in papillary thyroid cancers, we were able to find 65% of all cancers with these 7 gene isoforms. The problem is that 35% of cancers still had no identifiable gene mutation, or at least not one we could test for. So this test was very high specificity with a very high positive predictive value, meaning that if a mutation was present, the likelihood of a malignancy was very high, close to 100%, but it had very poor sensitivity and a poor negative predictive value, meaning it wasn't a good test for ruling out cancer because so many cancers could not be tested with this very simplistic approach. The big revolution was next generation sequencing, and the reason is because prior to next gen sequencing, what we were doing was Sanger sequencing and melting curve analysis. We were doing tests in series where each gene that we tested added incremental cost to the overall cost of the entire test. So price and cost became a rate limiting step. But once next gen sequencing came around, it was just as easy and just as cost effective to test for 100 genes as it was to test for 1 gene or 10 genes. So we were able to massively expand the number of genes that could be tested at relatively no further incremental cost. So by 2012, we knew that there were quite a number of other genes that were not so highly prevalent, but still very informative. And we were able to expand the 7-gene panel to increase sensitivity to 78% using targeted next-gen sequencing. Whole exome and whole transcriptome genomics allowed us to add a little bit more sensitivity. But it was with the advent in 2014 of the Thyroid Cancer Genome Atlas study, which I'll talk about in a second, that we really started understanding, at least for papillary cancer, what made these tumors tick. And that's where sensitivity really climbed to, I think, a very important level of about 95% for the first time. So what's the Thyroid Cancer Genome Atlas project? It was a project sponsored by NIH, and this was done for many different kinds of tumors. We were lucky enough that there was one done for thyroid. You'll see this rubric throughout the talk, so let me just explain what you're looking at here. These colorful bars on top are read vertically, and each vertical line represents information about a single tumor in the study. There are about 500 tumors in this particular panel. The colored lines are the clinical information, tumor purity, age, gender, whether there's a history of radiation exposure, et cetera. And then as you go down vertically, you start to get colored boxes that tell you about the presence or absence of various genes that were tested. The top box is somatic mutations. These are point mutations. Like BRAF and RAS mutations, which I referred to earlier. The second box down are gene fusions. So these are most commonly like RET-PTC. You may have heard of these before. And then the third box down are copy number variations. And if you look at what this tells us, it tells us that about 75% of all early stage papillary cancers can be identified by the presence of a point mutation. Another 15% or so are identified by the additional presence of a gene fusion. And then in another 5 or so percent, copy number variations, which are whole chromosome arm level defects in gene copy number, will describe another 5%. So in total, this is about 95% or 96% of all papillary cancers, which could be identified to have a discrete driver mutation that was identifiable that we could then turn into something on a diagnostic assay that would allow us to identify these tumors. The other important development that came from this study is this idea of classifying tumors either as BRAF-like. Let me back up for 1 second. I just want to make one more point. again, as I commented earlier, the most common mutation in all papillary cancer, so all of these cases are BRAF V600E mutant thyroid cancers. This is the most common tumor that's described in papillary cancer. It's important here because the paper also showed us that we could identify tumors because they behaved more like a BRAF V600E mutated tumor or more like a RAS mutated tumor. And that was based on thyroid differentiation. So this is sort of a heat map showing whether the tumors in the study were more BRAF-like or RAS-like. And that was based on gene expression. And if you look at this, you may recognize some of the genes like thyroglobulin, thyroid peroxidase, SLC26A4, is pendrin, which is the apical iodide transport protein. SLC5A5 is the sodium iodine symporter. And you can see that BRAF-like tumors de-express these thyroid-specific genes in green, and RAS-like tumors maintain expression, normal expression of those gene elements, and these tumors segregate nicely into these two classes. For people that are interested in cell signaling, this has a lot to do with flux through the MAP kinase pathway, the mitogen activated protein kinase pathway, where a kinase protein signals through RAS, then through RAF, in this case, the BRAF mutant, to MEK, ERK, and then ERK translocates to the nucleus. And that's this output heat graph that's shown up here. So much more flux through that pathway when BRAF is constitutively activated. When RAS mutations, the signaling molecule right above, are activated, there's much less signaling through the pathway, and that correlates with this observation of gene expression and de-expression. So what do we know about these BRAF-like and RAS-like tumors? Well, BRAF-like tumors are typical classic conventional papillary cancers. They have papillary architecture. They show the bizarre nuclear forms consistent with papillary cancer. We can also see infiltrative follicular variant papillary cancers. They have a very characteristic ultrasonographic appearance, very hypoechoic microcalcifications, spiculated margins. If you see this on an ultrasound, you can be almost certain that what you're looking at is a BRAF V600E mutated papillary cancer. That's how pathognomonic this is. So these have the classic features. They can be infiltrative. They spread to lymph nodes first and later to distant sites, and they de-express the genes associated with thyroid differentiation. On the other hand, RAS-like tumors maintain histologically follicular architecture. They look more like normal thyroid tissue under the microscope. And the way we know that they're cancer is they develop invasion into the capsule, invasion into the blood vessels. So that is the follicular thyroid adenomas, follicular thyroid carcinomas, and this transitional lesion that I referred to earlier, the NIFT-P, which is probably a precancer, the best way to describe it, as well as invasive encapsulated follicular variant of papillary cancers. These look distinctly different from papillary cancers. They look, as Mitch Tublin, a colleague from University of Pittsburgh, used to say, like a potato in the thyroid gland. And while that is a little bit simplistic, I think it's extremely descriptive. And if you remember that, you can appreciate that these nodules really look different. So the nuclear features of papillary cancer are absent in these tumors. They are encapsulated. They spread to distant sites because they spread through hematogenous spread and rarely to the lymph nodes. And they retain the expression of the genes associated with normal thyroid differentiation. Among the other important observations from this analysis were identification of TERT mutations. TERT mutations are telomerase mutations, and many people know that maintaining the telomere in the cell has something to do with the senescence clock and how it's programmed. You can think of this that when you have a TERT mutation, it is that's constitutively activated. The telomeres stay elongated without any restriction because they're constantly repaired by the TERT process. So these cells never go into programmed cell death, and as they hang around, they can pick up other mutations and basically degenerate into cancers. If we look at tumors like papillary cancer and pull out the more histologically aggressive group, the tall cell variant papillary cancers, if we look at Hürthle cell carcinomas that are minimally invasive or widely invasive, or poorly differentiated cancers, you can see that TERT mutations are highly prevalent in the more aggressive forms of all of these cancers. So it's an independent marker for cancer virulence, if you will, or aggressivity. And there's data that shows that when you look at TERT mutations versus isolated BRAF mutations versus tumors with no identifiable mutation, the behavior is very indolent, but as soon as TERT gets involved, much higher risk of recurrence, or in this case, decreased recurrence-free survival. Mortality can be shown to increase when TERT mutations are present. And this last slide on the right is very important because it shows that TERT is an independent prognostic marker for mortality among patients who all have American Thyroid Association high-risk disease, meaning very invasive, widely metastatic disease. If you look at them histologically or in terms of their clinical course, they may look identical. But if you segregate out the group that has tumors that show a TERT mutation, those groups have a markedly decreased survival. So this is an independent predictor of death in that important group. The same type of analysis that was done for the thyroid cancer genome atlas was also done for follicular thyroid cancer, and they compared it to papillary cancer as well. What they found also is that follicular cancers similarly segregated into RAS-like tumors, BRAF-like, and a small group of these non-BRAF, non-RAS tumors. We've looked also at medullary thyroid cancer, which derives from not a thyroid epithelial cell, but from a neuroendocrine C cell, the parafollicular C cells in the thyroid gland. These are a different type of tumor. The most common mutation found in sporadic medullary cancers are mutations in the RET oncogene and in RAS to a lesser extent. And this is an important step forward in understanding the genetic basis for these tumors as well. If we look at poorly differentiated and anaplastic thyroid cancers, a similar analysis, again, vertical lines representing each individual tumor. This is very nice work from Inigo Landa at Memorial Sloan Kettering, where he looked at poorly differentiated thyroid cancer on the left and anaplastic, the most aggressive human tumor known, on the right. And what he found was that many of the same mutations that we identified in early stage cancers were still present, and likely initial oncogenic events in these tumors. But these tumors had multiple secondary and in many cases tertiary hits of different gene drivers that increase the aggressivity of these tumors, like TERT, like P53 and others. And if you look at the average mutational burden in these tumors compared to a straightforward plain vanilla papillary thyroid cancer, which typically has a single driver mutation, anaplastic thyroid cancers had a mean mutational burden of 6 identifiable mutations, and poorly differentiated thyroid cancer had a minimum of 2, a mean of 2. And when we also pull out the tumors that had fewer than the mean number of mutations, the black line here, their Kaplan-Meier survival was better than the tumors that had a greater than the mean number of mutations in the red line here compared to the mean in green. So important observations again about how these driver mutations lead to oncogenesis in thyroid tissue. The last tumor type I want to talk about is something called a Hürthle cell carcinoma or Hürthle cell tumors. They're now called oncocytic tumors. These are relatively bland, dense nodules on ultrasound. You can see here, it doesn't look like anything too spectacular, just one of those potatoes that I was talking about before. They're very fleshy tumors on histology. They have a very characteristic kind of open chromatin pattern in these very large nuclei with very granular generous cytoplasm. They're often called Orphan Annie eye nuclei. If you've never seen Orphan Annie, that's what she looks like. Her dog looks like that too, so they could have called it an Orphan Annie dog nuclei, but they don't. The problem with these tumors is that they can be very aggressive, they can metastasize, and we've also come to realize that they don't involve the same driver events that other forms of thyroid cancer basically have. So a lot of research has gone into this particular group of tumors. Even though they're rare, 5% of all thyroid cancer, they're incredibly important because when they happen, they can be extremely aggressive and difficult to treat. So here's what we know about oncocytic cancers. We know that these are very mitochondrial dense tumors. They're abundant mitochondria if you look at these tumors under the electron microscope. And there are a number of mitochondrial DNA mutations, specifically in the succinate dehydrogenase chain in complex 1. But the most important event, genetic alteration in these tumors, are these chromosomal copy numbers. So let me just take an extra minute to talk about that. So here's the typical sort of representation of a diploid genome with one gene that is inherited from the mother, one gene that's inherited from the father, and through mitosis, that diploid genome is maintained. If you look at what happens in chromosomes that are undergoing copy number alterations, there is loss of one or the other of those chromosome alleles. And in the more advanced cases, there can be reduplication of one of those parental alleles so that you now have two chromosomes, but they are identical copies of an original parent chromosome. And this is the haploid, lost my pointer. This is the haploid genome state that we're looking at here in the middle. And this is something called uniparental disomy. And what we've come to realize is that the amount of aberration in the chromosomal copy numbers for these tumors is very important for understanding whether they are in an early stage of oncogenesis or an advanced stage. So too is the presence or absence of point mutations like TERT promoter or P53 along with others. And when you combine chromosomal copy numbers and DNA point mutations, you wind up with the most aggressive Hürthle cell cancers. That was shown very nicely by Ian Ganley, again from Memorial Sloan Kettering a couple of years ago, where he broke up these Hürthle cell cancers into widely invasive on the left, minimally invasive on the right. The widely invasive tumors had a 25 or 30% rate of distant metastases, whereas the minimally invasive tumors on the right were far more indolent. And again, same rubric with clinical information on top and each vertical line representing a tumor, colored boxes showing which mutation was present in the specimen as they were analyzed. What we can see is that there is an increased number of copy number changes in the more aggressive tumors. And if you drill down on that further, you find that not only are there more, but it's more bizarre copy number changes, changing from a normal diploid to a haploid and even to a genome that then shows very widespread uniparental disomy. There are also mutations like TERT mutations, far more prevalent in the aggressive tumors as well as others. So we do now understand quite a bit more about Hürthle cell tumors and Hürthle cell cancers than we ever did before. And all of this comes together in this way. What we can learn from this information is that there are relatively few genetic events that now underlie most thyroid tumors, like point mutations, single nucleotide variations, insertion deletion events, gene fusions, copy number alterations, and gene expression alterations like overexpression of calcitonin and chromogranin A in medullary cancer. The American Thyroid Association has created a way that we can risk stratify tumors based on their histologic appearance, but they've started to incorporate observations about genetic events that inform risk stratification as well. We can overlay what we were just discussing, and we can say that RAS mutations are really the lowest risk, least aggressive forms of thyroid cancer. The BRAF-like tumors are more intermediate, and these tumors where multiple genes co-occur are the most aggressive. So it's natural to try to turn these into a diagnostic test, and here's the way that all diagnostic testing is done. We get a sample, we may look at it under a microscope, but the sample that we run on some sort of machine that looks at the genetics is something really clever, and then we come up with risk assessment. And the two biggest tests that are commercially available now are one that's marketed by Veracyte, it's the afirma GSC assay. It's an RNA-based gene classifier. And they offer a secondary tool called the Gene Expression Atlas that further refines the diagnosis of their first tool. And the ThyroSeq test, which I had the pleasure of working on in an early form at UPMC, which is a multi-gene next-generation sequence assay. So let's take a look at both of these. So what's the ThyroSeq test? Well, the platform is a next-gen platform that basically looks at a lot of gene hotspots and gene fusions. There are some screening cassettes to assess cellular adequacy and non-thyroidal tumor. types to exclude those from further analysis. And then if it looks like this is a thyroid specimen with adequate cellularity, it goes to the main classifier where point mutations, fusions, indels, and copy number alterations, gene expressions are analyzed. And the output of the test is a report of the actual genetic alterations that are observed and the allelic frequency, how prevalent they are in the tumor. And it's correlated with something that's unique to UPMC, where they have an incredible database of genotyped patient nodules with surgical outcome that allows the prognostic and diagnostic validity of these observations to be supported. The afirma GSC takes a different approach. It's also now next-gen sequence-based, screening cassettes, a core gene analysis, and then additional screening cassettes at the end looking for particular tumor types like Hürthle cell nodules. And then they report that their specimens are either benign or suspicious based on a machine learning algorithm that is analyzing gene expression, looking for the signature of either a benign tumor or a malignant tumor. So this doesn't actually look for the driver mutations. It looks for other gene expression signals that are consistent with benign and malignant tumors. So a slightly different but valid approach. There have been numerous validation studies, independent validation studies of both the afirma test and the ThyroSeq test, but probably the two most important are the ones that were published in JAMA in 2018 and 2019, I think. This is the summary. It's important to realize that when we're talking about validation of these tests, we're not talking about numbers like we see in cardiology studies where there are 10, 15, 20,000 patients included in a cohort. These are 250 approximately and 190 nodules included in each of these validation studies. You can see the number of cancers was 68 for ThyroSeq, 45 for afirma. There is always a missed cancer rate in these various categories of indeterminate Bethesda 3 and Bethesda 4, and that results in a negative predictive value and positive predictive value that I think is quite useful. Negative predictive value of 97 and 96%, meaning that there's a 3 to 4% residual cancer risk if these tumors test negative with one of these tests. The positive predictive value is more intermediate. The take home is that both of these tests offer a benign call rate of about 80%. And that shouldn't be shocking based on that pie graph that I showed you early on, where we know that about 80 or 90% of all indeterminate thyroid aspirates turn out to be benign. So basically a benign call means that the test is negative and therefore surgery can be deferred. So this is a big step forward because now we're able to manage these patients expectedly without doing diagnostic surgery. And I think this is arguably a major step forward in evaluation of thyroid nodules. If you look at cost, there is some cost modeling data. Diagnostic lobectomy is the least costly in terms of a case, less costly than either the afirma or the ThyroSeq test. But in terms of cost per correct diagnosis, diagnostic lobectomy is the most costly because it takes a lot of diagnostic lobectomies to find a relatively small number of cancers, less so for the genetic tests, which are both less expensive per correct diagnosis compared to diagnostic lobectomy because so many of the nodules are called benign and shunted into observational management rather than surgery. So what's the take home? The high negative predictive value allows observational management in lieu of surgery in about 80% of tested cases. There's a residual cancer risk of about 3 to 4%, which is roughly equivalent to benign cytology. In terms of future directions, I think we're going to be looking at prognosis. We're already learning things from molecular diagnostic testing about like TERT mutations and their prognostic importance, but I think there are going to be more developments very soon in the future that will tell us about the clinical course that these patients will follow based on the gene endowment. Can the extent of surgery be informed by the genetic profile of positive cases? I think that's coming, and there is at least one group that I know of that's working on this very question now in a clinical trial. And can we better predict or better select adjuvant therapies like radioactive iodine or targeted therapies based on the genetic profile of tumors? I think these are all the future directions for molecular diagnostics. The last thing I want to talk about in about 5 minutes is radiofrequency ablation. This is an important new technique that allows us to treat and basically extirpate thyroid nodules non-surgically. This is a typical setup where the patient is supine. The electrode that's used for the procedure is connected to a radiofrequency energy generator and a water pump because these electrodes are internally water cooled. There's a grounding pad on the patient. The operator typically sits at the head, and the procedure is done under ultrasound guidance. The needle electrode is inserted, and when it's activated, a very controlled small ablation zone is created where a little bit of thermal energy necroses the tissue. And by moving the electrode through the nodule in a very sequential way, you can ultimately destroy the entire nodule with this procedure. That's a picture of me doing a case with the ultrasound transducer in one hand, the RF transducer in the other. You can see up here on the ultrasound, the needle, which is coming in from the left. The anatomy here, I'm right next to the carotid artery. The tumor I'm treating is here. And here are some phantom clips of what this actually looks like. When we insert the needle, you can see very clearly the needle being inserted into the nodule. And then as we're treating the nodule, what we're looking for is this white area, this hyperechoic change, which is the tissue coagulation that's taking place as that needle is activated and slowly removed through the nodule. And then that's repeated until the entire nodule is destroyed. The RFA was only approved in the United States in 2018, so there's still a very limited US experience. That's not true primarily in Asia and to a lesser degree in Europe, where far more of these have been done, where there are literally thousands, many thousands of published cases. These demonstrate excellent outcome for treatment of benign, symptomatic, and even autonomous thyroid nodules. They are also demonstrated as an effective treatment for inoperable thyroid cancer recurrence in the neck. And there's a growing literature for treatment of intrathyroidal small papillary cancers with radiofrequency ablation. Put this slide in just to show you that it's obviously a very active area of research over the last 15 or so years. The number of publications in Medline about thyroid RFA has skyrocketed. And we hope to be adding one very soon to that list. This is unpublished data of the group I'm working with in New York. This is combined data from 3 academic centers where we've now done 77 nodules, the interruption from COVID notwithstanding. And what you can see is that starting from the baseline volume, following up over time at 1, 3, and 6 months, there's a fairly expected but very typical reduction in size of about 2/3 at 1 month, up to about 75% or so at 3 months, and by 6 months, 83%. And I expect that there'll be incrementally further decrease that we observe at 1 year when we can get these patients back in for follow-up now that the pandemic is starting to ebb to some degree. These patients receive a symptomatic benefit when they have compressive symptoms, generally within 1 to 2 weeks. We treated 7 patients with autonomous or toxic nodules, all of whom were able to stop their anti-thyroid drugs and remain euthyroid. There was absolutely no hypothyroidism that developed in this cohort, and that's typical of this type of procedure. The procedure is safe. This is the largest meta-analysis of radiofrequency ablation that I know of, about 2,800 nodules from studies from all over the world. 17 studies that included benign nodules, 7 studies with cancer. The most common complications include the minor complication of pain, which is typically mild to moderate, doesn't prevent completion of the procedure. The most common major complication, which is not common, but the most common complication, that's the major complication, is voice change due to typically transient injury of the recurrent laryngeal nerve. If you look at the occurrence, the overall recurrence for both of these complications is extremely low and not dissimilar from what you'd expect from surgical management of the same nodules. An interesting observation is that the cancer cases that are usually more complicated, the risk of complications is somewhat higher. So the bottom line here is that it has a low complication rate that compares very favorably with surgery. The more complicated cases, as you might expect, are the ones that are harder to do, where more complications are common. But the key points are this is an ambulatory procedure. There's no general anesthesia involved. It employs a 19-gauge needle with a puncture site that heals without a scar. It's done with local anesthesia only, where I do it in New York, where everyone's crazy. I give them a little bit of alprazolam too. The procedure duration is about 30 to 60 minutes. We see excellent volume reduction. It's an effective treatment for autonomous nodules. Hypothyroidism almost never occurs with this procedure. It's useful for berry picking small recurrent thyroid cancer metastases and has some early indications for primary treatment of intrathyroidal cancers. But the major downside is that there's no current CPT code. So this is a cash pay procedure that costs anywhere from $3,000 to $4,000, depending on where it's being done. This patient consented to have her images shown. So this is a pre-ablation image where I think you can appreciate the large right lobe thyroid mass that you can see here. And this is a six-month follow-up where she's had about a 60% reduction in the size of the nodule. And I think you can appreciate that from this clip on the right. So I think these are typical results, and I wanted to show this just so you could see an example. And this particular patient had really significant compressive symptoms, and she was delighted and called me about a week later to tell me they had almost completely resolved within a week of the treatment. So I started the talk with this slide from over 60 years ago, noting that we're still trying to figure out the best way to evaluate and treat thyroid nodules. I think we're still very much doing the same thing. We talked about surgery, cytology, ultrasound, molecular markers, and I think one of the most recent contributions, which is radiofrequency ablation. I'll stop there, and I thank you for your attention. If we have time for questions, I'm happy to take any questions that we have.
Thanks, Steve. That was